first, I just wanted to thank everyone for the opportunity to go through this presentation. This discussion is really one that I think is very pertinent to the disruption that has occurred in all of our lives, especially within the healthcare industry related to COVID-19. The statement on this particular slide, I think, is probably not a surprise to anyone, but the level of disruption that's been created across the board, I think, is very profound, and each of us as individuals has unique experiences that we can share as far as how it's impacted each of us. But what it has really done, in my opinion, is expose some extremely serious flaws in the delivery system, and most importantly, employer-sponsored health insurance. This is a busy slide, but this top graph that we look at right here is a breakdown of market segmentation. So, Medicaid, Medicare, the self-insured market, and the other category. But what a lot of folks don't seem to realize is that the self-insured marketplace provides health benefits to approximately 145 million members in the United States. Now, this was all pre-COVID. This is a slide from the Kaiser Family Foundation, and one that we update. But you can see that represents roughly a 45% of the population of the United States is in a self-insured environment. You can see the respective metrics for Medicare. And then the other column is rather interesting, that it's 47.1 million, or 14.6% of the US population falls into that other category, which is your fully insured, your individual and small group, and your uninsured. And so when you really think about the target of the Affordable Care Act in expanding access to care, it's really, excuse me, that other category where that is most impactful. Because for the most part, you can see that the majority of the populations in Medicare, Medicaid are a self-insured commercial environment. But the key challenge here then, recognizing this distribution, is really that bottom chart that is representative of the unemployment rate as the COVID-19 pandemic really began to have its impact, and the various strategies that were employed throughout the US to try to slow down the spread of the virus. We were clipping along at a very strong economy at 3.7 to 3.5% unemployment until April of 2020. And you can see that we peaked at 14.7, and even through June of this year, we're at 11.1%. So, in the bottom right-hand corner, I think it's those particular metrics that approximately 20 million people at one point in time have lost their jobs. Now you can see that folks are getting back to work, but not at a real accelerated pace that gets us back to that full economic level of employment that was pre-COVID. But as recent as last week, it was estimated that as many as 10 million people in the United States have lost their health insurance coverage as a result of the COVID-19 epidemic, which then really goes to this other category on what's going to happen when we move into the open enrollment process. Because, we've got a lot of folks unemployed. If you're unemployed, you're not earning money. And, the relative cost of healthcare is not a bargain by any means. And especially when you get into the exchange environment, if you do qualify for premium subsidy, that's great. But if you don't, and you're in a family of four, it could cost you $25,000 a year just to provide health insurance. So, there's still, I think, a lot of pain and a lot of issues that we're going to be facing as we continue to go forward and either recover out of this and get to a point where there's control over the virus, or wondering what's next at this point. So, and these are some thoughts as we've gone through this, but one of the key things that seems to be self-evident to me is that the US doesn't really have a healthcare system. Healthcare delivery in the U.S. is really compromised of local and regional health systems that don't compete in a normal supply and demand economic environment in the commercial market. That's maybe a harsh statement to some, but I think it's a statement of reality. Whether health systems are not for profit or if they're for profit, in my mind over the years has become really irrelevant, because it has more to do with how capital is raised and how expansion and services are delivered. But the basic issue is that whether it's a system is not for profit or for profit, they all behave similarly, and the pricing that has occurred in the environment of healthcare is out of control, and it's not sustainable. It's I think complicated by the fact that Medicaid and Medicare dictate pricing to the market. They don't negotiate pricing, but there seems to be a basic disconnect among Medicare, Medicaid, and the commercial marketplace as to what is a reasonable price. And consumers are really stuck in the middle. It's predominantly that fee-for-service environment in which discounts cloud the true cost and value of care being provided. A lot of the work that we do when we work with self-insured plans is we get their data and we reprice their current data, and we reprice it back to Medicare allowed so that we can actually establish a baseline. And, it varies all over the country, and I think we're all, likely aware of this, but, it's not uncommon to see build charges in the provider component or the facility component range anywhere from 350 to 850% of Medicare allowed. And then when you look at the fact that, the PPO or the managed care allowed amount that then is actually paid for those services typically is averaging around 220 to sometimes as high as 400% of Medicare. And then you've got specialty outliers like anesthesiologists. Many of them are non-contracted, or if they do contract, we still see anesthesiology contractual allowed in the 1,200% of Medicare range. So, and I'm not saying that Medicare is right, but it's a benchmark. And when you begin looking at things from that perspective, it doesn't really matter that you're getting a 55 or a 65% discount. What really needs to matter in the discussion as we're looking at price and cost is it reasonable related to marketplace, and are you getting value out of that? So, it's really a challenge, but I think right now this whole COVID disruption is really ripping this Band-Aid off to a point where it's very painful for a lot of folks, and then you start looking at the cost of specialty drugs. It's out of control. We have an account that we manage up in Montana that's a public entity that has an individual whose drugs cost $50,000 per month. And when you look at how that negatively impacts that public entity and their ability then to actually, siphon money away from their mission of educating children to basically having to provide for the cost of that one individual that has a very rare and unique, circumstance, you start to wonder about the whole process of the cost basis and how do you start getting control of that. So a couple of the other problems that we see, that cause this, and I just use the example of a specialty drug, but the medical GPO and pharmacy supply chain incentives, they drive high costs, and the lack of price transparency and accountability within that mechanism is really quite disturbing in my mind. The lack of interoperability of electronic medical records, that in my opinion should be patient and consumer specific, not health system specific. There's organizations out there that provide these electronic medical record systems. And, if you've seen one Epic environment, you've seen one Epic environment. And, the need for those environments to basically begin to function more as a utility, I think, is extremely important and needs to be addressed at as immediately as possible. But in my opinion, medical records should be specific to the consumer, to the patient, and not basically controlled through an institutional type of an environment. I think moving that out to consumers will allow much greater awareness and actually information for consumers to begin to act like a consumer as they procure health insurance services and then healthcare services. So, you know, we can go on and on and on with a lot of the things that we, you know, could list as flaws. You know, these are just some that I've written down. Each of you in your own opinion and viewpoint probably have others that you would add to this. I think this slide is one that is really beginning to true up a little bit. Is, you know, what is the potential cost impact to the marketplace? So this is a table that was taken from a Milliman study. Milliman being one of the preeminent actuarial firms in the country, that, you know, they're looking at a potential cost impact of different scenarios by the end of 2020 being, you know, as low as about $90 million impact to as, or excuse me, 90 billion to as high as 600 billion. And, you know, what's alarming to me is at the point that this was created, and the point that you can see each of these data points of the different scenario testing that they did, that's not really a very comforting range of potential outcome. You know, when you look at, as we're now at the end of Q1, now we're at the end of Q2, but by the end of this year, having this type of a range is rather alarming. And we are beginning to see some of this true up, but I think it's going to take a while, and we may not know until we're well into 2021 what the actual cost base of this epidemic has been to the marketplace. But we do know that there's a lot of other costs that have begun to happen. One of them is in the area of primary care providers that were, you know, almost exclusively fee for service, and in contracts where, you know, during the months of March, April, and parts of May, they essentially were shut down. So, you know, how does that impact weigh into these types of things where, you know, you have physicians that, you know, have either quit, they've retired, or, you know, they've had to find other means. And there's been some really significant success stories with organizations that were in, you know, the capitated primary care models, the value-based primary care models, where some of them, a couple of which we work with as clients, they essentially were able to take their primary care environment and their value-based model and essentially be in a telemed model within 3 to 5 days of the shutdown when it occurred, you know, around the March 16th timeframe. You know, those types of stories are out there, and they're beginning to attract a lot of those physicians away from fee for service into that partial or global capitated environment where they're at least guaranteed that, you know, they've got revenue streams that will continue to flow. But, you know, you go back to that initial slide where we talk about the number of employees in the commercial market that are in a self-insured environment. Self-insured employers are not really embracing a lot of the capitated primary care models yet, but I think they're beginning to because of the disruption that was made. So there's opportunities there. What kind of started the discussion with myself and Shelley and Matt a few months back was an article that was written in one of the employee benefit magazines. And it basically laid these concepts out of what to expect in 2021. And when I looked at these and Shelley and Matt and I began talking about this, what we began to see, and I take exception to a lot of these particular items, you know, a movement toward consumer-driven health plans. You know, that's what you should expect as an employee. You know, and I really take exception to that because in my opinion, high deductible health plans are the worst indictment of the health insurance industry's ability to actually manage risk and contain cost. All CDHPs are, in my opinion, are cost shifting. And at the same time that these high deductible health plans have become the norm, and especially with the passage of the Affordable Care Act and all of the subsidies being tied to those silver plans that are high out-of-pocket plans, in my opinion, I think the Affordable Care Act and the health insurance industry has done consumers huge injustice by moving them into those plans, and which are nothing more than cost sharing, or excuse me, cost shifting. And we'll talk a little bit more about that as we move into this discussion. But yeah, healthcare is going to be more expensive. But, rather than, sitting around with a bunch of academics and talking about bending trend, there are ways that you can actually reduce cost and eliminate a lot of the intermediary play, so that you're bringing consumers and patients closer together, and actually then stepping down or eliminating out-of-pocket cost. So for example, one of the areas I think you've probably surmised in my comments, I'm a very strong promoter of community-based capitated primary care. Because if you can make that component cost to consumers at zero, you've actually now accomplished something. So one, you've basically created a better environment for primary care physicians to exist, because they're not at jeopardy of having something in a fee-for-service environment like COVID-19 basically take them out of the game for a period of time, and they have zero income. That capitated environment allows them to continue to provide services at a point in time when people really need it. And in my opinion, if you do it correctly, the price of primary care to a consumer should be zero. There should be no reason to create financial barriers to care in that primary care segment. So again, I am not a proponent of high deductible plans, and I'm not a proponent of health savings accounts. I personally, participate in a high deductible plan, and I participate in a health savings account because I can afford to, and I use it as a retirement plan, and I max out as much money as I can throw into that personally each year. But I'm the rarity. There was an article that was published just a week ago that went through a whole process of showing how the high deductible plans have really been such a disservice to the general public, because the majority of people that participate or have these high deductible plans either do not have an employer sponsored HSA to support it so that they can actually accumulate savings, or they themselves are in a job or a position where they may be employed, but they can't afford to barely even pay the contribution for those high deductible plans to participate to begin with, let alone contribute to an HSA. So the number or percentage, I believe, and this is by memory, was something like only 26% of those people that are otherwise eligible to participate in a health savings account actually do. So I think there's just becoming more and more metric and opinion toward these high deductible plans actually being more of a disservice. Consolidating of benefits and plans, that's actually something that is probably a positive. When you have choice in the marketplace, and especially if you're a single employer and you're offering, plan A, plan B, plan C, each of those plans, especially in an experience rated environment, whether you're fully insured or whether you're self-insured, your experience is still a big driver of what your ultimate cost is. Choice is expensive. So, creating plan design that incents appropriate consumer behavior and also begins to draw the patient and the consumer closer to the providers, I think you're going to start seeing a lot of movement in those types of plan designs, and we can talk a little bit more around that. And then, prioritizing and promoting preventive care. That's great, but wellness, for the most part, it doesn't work in the way that wellness has been defined. And I think that that is another area that needs to really be focused and looked at. Again, I'm promoting and very strongly believe that primary care works, but you then also delegate the chronic care management of that particular population to those primary care providers. And when you look at that in the successful value-based models that exist throughout the United States, it is exemplified that when you do that in that appropriate setting, that you start to get better outcomes and you start to get better health results on, within the population that you as an employer or otherwise are responsible for. Education, it's tough. Education, most employees, most consumers, most people in the United States, healthcare is complex. How do you dumb it down? How do you make it more simple? And again, one of those areas is back to the primary care model. Embracing new normal, telemedicine, I think is awesome if it's tied to the provider. What I don't like, and what I have observed over the years as telemedicine has evolved, is having telemedicine for the sake of having it and just creating a separate silo that sits outside of the relationship between the physician and a patient. I don't think that's good telemedicine. Having telemedicine that connects the patient and the provider, I think you're going to see those models create much greater value as you go through the process. But part of that then becomes education of the member. What are the different access points that members can have, and how do they use that to the best advantage? How well are value-based services being provided, as far as the whole medical home concept and the ancillary services that these patients and members can access. But education's difficult, and it needs to be very population focused. One of the groups, for example, that we manage in the state of Oregon has 25,000 home care workers. And one of the things that's really unique about this population is that there's not a centralized workforce. And, these are folks that are assigned by Medicaid to go out into the homes of Medicaid disabled individuals and care for them in the home setting, rather than having those disabled Medicare individuals be institutionalized. It's a very unique, delivery system of services. But in that population, we've identified 19 different languages and cultures within that population. And so when you think about education and you think about, the medium through which you're going to begin pushing your messaging out, I think more than ever today, we have to really be super sensitive to the demographics of the populations that we serve, and how do we communicate, and how do you bring that down into a community-based level that is very focused on those social needs of those populations. I'm not going to spend a whole lot of time on this. I think, I've talked about this early, but this is just some additional support for some of the comments that I was making earlier. But I think most importantly is that, a lot of these plan designs, they don't address the actual cost of care. And I think that's where one of the biggest disconnects is an opportunity for each of us to really start looking at, how do we change this? So the first bullet here can be kind of controversial. Where's the absorption of risk by the health insurance industry? That at a time where they book extreme profit and growth and reserve accumulation. That's a harsh statement, but I spent a number of years in the commercial health insurance side. I spent a number of years within the Blues as I progressed through my career. And, great organizations with really good people focused on doing the right thing. And, individuals within these organizations, they've got great families and all of that. That's not what I'm saying. What I'm getting at is that the incentives in the marketplace in which health insurers and health systems and health and PBMs and pharmacy companies, the environment in which we all exist today has some of the most perverse incentives for managing to the benefit of consumers and patients, I think, that I've ever observed. And as I've been in this business longer and longer, I become more irritated about it and more outspoken. So, one of the areas that is a very challenging area for me within the Affordable Care Act is the minimum loss ratio provision that essentially says that, health insurers have to meet a loss ratio of X, otherwise they have to then, refund excess back to the policyholders they serve. But the unfortunate part of that is it's based on percentages. And having worked inside a blues organization in the 1990s and into the 2000s, one of the things that we observed is across our entire book of business that our expense loads and our fixed cost were at or below 10%. Now, again, that's historical. It goes back 20 to 30 years. I realize I'm aging myself here. But the point is that those organizations were extremely disciplined in keeping their expense loads at or under 10%, meaning that 90 cents on the dollars was actually going out in the form of paying for benefits and paying, for services on behalf of their policyholders. The Affordable Care Act takes that and basically moves it up to 20%. And so what do you think happened? There was no incentive for costs to basically stay at a particular levels. And the next thing you know, you start seeing, the cost of healthcare since the ACA go through the roof. The word affordable should be taken out of the ACA because it's not done anything to basically create affordability of healthcare. If anything, it's actually fueled the growth and expansion of healthcare costs that's been exponential. So, that's an example of one of those types of items that I just think, has to be addressed as we go forward. But the key point that I want to make is that last bullet. Buyers pay for healthcare with their own money and contributions of their own employees. Insurance carriers are payers. They are not buyers. Regardless of how we may view them, I think that this distinction needs to be made in the marketplace. And I think when you begin to do this, then buyers of healthcare, being employers in local communities, have great opportunity to change the discussion in their local marketplace and really start to go past the insurers and go directly to these health systems and provider groups and say, we need a better way of doing this. And we'd like to be able to do, something different than what's been done. Because, again, in my opinion, for the last 30 to 35 years, the whole evolution of managed care, of PPO networks have basically failed. And I think that there are a number of employers and consultants and brokers out in the marketplace that basically are looking at the health insurance industry and saying, guys, you blew it. You had 30 years to basically try to keep this under control. And we've seen nothing but, straight up, low left to upper right trajectory of claims cost. And that, it's not sustainable. Businesses cannot continue to sustain it. Consumers cannot continue to pay the levels of prices in the market. And when I mentioned earlier, I think it was the most recent Milliman study came out that he basically places the average cost of a family of four to pay for health insurance and a high deductible plan is in excess of $25,000 a year now. And when you start to place those types of costs out in relationship to other expenses like mortgages, food, insurance of other things, it's obviously not sustainable. And I think that COVID-19 is creating that disruption that we either figure out how to fix it or we're going to crash and burn. So I think we can all talk all day long and I get on a roll, but the key is that we believe that the future of healthcare needs to be local, it needs to be open, and it needs to be independent. And I'm not, pointing fingers, but I don't buy into this notion of health systems buying up physician practices. I think that model has failed for the most part. Because, you've got physicians who are now employed who don't have incentives, but, when you've got health systems that are primarily facility and hospital centric, their basic, need is to have heads and beds. And, the role of primary care is more creating piecemeal in a fee-for-service environment in the ordering of labs and the ordering of radiology. And, there's all kinds of metrics out there that show that there's huge amounts of waste. But, there's metrics out there that also show that, if this is the primary care component, these are salaried primary care providers, that a lot of health systems view their role is feeding the specialty doctors and what they charge, that ultimately feed into the hospitals in the form of keeping their census as high as possible and keeping those bed days as high as they possibly can. And that model has to change. I just, that's a whole separate series of discussion, but it hasn't worked. I think any of us that think that the cavalry from DC is going to come in and fix all of this is pretty short-sighted. There's a lot of, in the second bullet, a lot of great societal changes that we've been tackling over the last decades. The civil rights issue, that's really raised its head again recently, and always should be in our forefront. Energy independence, climate change, better food. It's all been fueled by bottom-up changes at community-based levels. And I think that this healthcare change is another area that needs to fit into these topics, because it's all intertwined. All of it's intertwined. And then, healthcare is particularly suited to a bottom-up approach, because healthcare delivery begins at the local neighborhood, local level. And, individuals want to have access to their primary care. And then as we move up in acuity, then you may have regional and then national strategies as you get into more severe and more acute cases. But the more intermediaries and bureaucrats that get inserted into a relationship between a physician and their patient, I think, detracts from value rather than adds value. National solutions, picks winners and losers, based on who's leading the discussion. I think that's a statement and a point that is really pertinent. What might work in Boston may not work in Detroit, and it's definitely not likely to work in Kansas. Where you move from the two coasts, where you've got lots of population and a lot of density, and you start moving into the middle of the country where, there's a lot of space in between, smaller towns, different structures of hospitals and delivery systems and access. It makes a big difference, because a one size fits all is not going to work. So the role needs to be, I think, more focused then on finance and risk management, and how do you create funds through whatever public methodology we choose to build out. But how do those funds get distributed to meet the local community-based level needs? And I think then that goes to, fulfill a lot of the discussion around the whole social determinants type of discussion, that, the social determinants in New York City are very different than what social determinants are in Wichita, Kansas. But an ultimate underlying issue is that it's still unaffordable. And that's really the primary issue that I think we have to address. Decreasing scale to local levels, solutions appear to problems that can seem too complicated to solve at a global scale. And so what we're really getting at here is that there are extremely bright, talented people everywhere in this country, and especially in healthcare. Some of the brightest, smartest minds I've ever met are, sitting within health systems and sitting within risk management organizations, and they're sitting within physicians. But a lot of it then, how do we create that focus that's consumer and patient oriented? And I think that's the challenge we have. But, when you look at that second bullet, that roughly half of every dollar spent on healthcare adds no value. Most of that money is being extracted out of a local economy, and it's moved up to these large, private equity firms and up to these large health insurance companies. I think that that's one of the first opportunities, is bringing that dollar and keeping it in your community. That's I think mission number one, is working your way through those types of discussions. And, the last bullet here, there's no way to transmit proprietary ideas at anywhere near the speed and coverage that open sourced ideas move. So, the arc of healthcare bends toward openness. So openness, open source, open sharing, transparency, but sharing ideas at those local levels, I think, is critically important. The good ones will rise and potentially, spread from community to community. Which is part of what we're beginning to see with a lot of the independent physician organizations that have organized themselves into value-based organizations. But transforming healthcare, it requires redoing health insurance to support the healthcare system. There's a lack of equilibrium because it doesn't mean, as we're saying here, that health insurance is a bad thing, but it means that health insurance needs to actually assume risk. And one of the things that is bothersome to me is how the health insurance industry, internal to their fully insured products, there's a component that's called a pooling level, so that they're pooling large claims, so that you've got a pool that consists of individuals or small groups in this fully insured pool. But yet many of the pooling levels of that pool, because of how the claims have inflated over the years, they're as high as $300,000 to any given one person, meaning that the pool takes the first 300,000, or it could be 350,000, it could be 500,000, that they're taking that $1 exposure up to that amount, and then everything else goes off into a reinsurance type mechanism. But what that's really done by not keeping those pooling levels low is it shifted all of that cost to the cost of the health insurance policies, because the health insurance industry hasn't done a good job of managing what's driving those large claims, and they haven't done a good job of keeping the overall cost to the marketplace low. Because every time you move up a pooling point from, let's say, 200,000 to 300,000 to 500,000, you're shifting that first dollar cost back to the cost of the health insurance premium, because you're absorbing more claims in those policies. And so, that's just a mechanical issue, but it's something that I've been very critical of the health insurance industry. So how do we bring risk back into the discussion where it makes sense? And more, there are a lot more abilities to create risk sharing mechanisms at the local level between the physicians, the providers, the health systems, and the consumer marketplace. And I think those types of financial and risk management strategies are very ripe for discussion and opportunity in a local marketplace. So, the openness of providing itself in an array of settings. This is kind of an interesting example. And this comes from a gentleman named Dave Chase, who is the evangelical leader of an organization called Health Rosetta. But this is an example that Dave utilized getting his point across. And so openness improving in an array of settings. So the beer market is mature. It's been dominated in the US by a couple of really large, Anheuser-Busch, Miller Brewing Company. And, they've grabbed, 24, percent of all the beer spending. But then craft beer brewers recently have grabbed as much as 24% of the spending. How did craft brewing, how did that basically evolve? Well, one, consumers like it better, they like the product better, and they like the fact that it's local. Craft brewers are radically open with each other, meaning that they share their recipes, they share their methods, they share, how did they succeed, recognizing that their real competition amongst themselves at the local level is the mega brewers and not each other. So, that's kind of an analysis that you could apply to, the institutional environment we're in now, that are all these huge, organizations, and pharma, the BUCAs, those organizations that have become quite large, versus, look at this example of how craft brewing is basically through open access of information and sharing have become quite successful. So a central tenet of the Health Rosetta is actually to create a open Wikipedia like hive mind, which makes it easier to understand and to deploy approaches that begin to outperform those traditional approaches, to quadruple aim type objectives. And so I would encourage you all, I'm a very strong supporter of Dave Chase. I'm a strong supporter of the message of Health Rosetta. And I would encourage you to read Dave's books and also, get an understanding of, how this type of mentality can apply to, what's going on in healthcare. So, the primary value creation in healthcare is fundamentally local. It's a contrast to the massive top-down. Scalability, seeks to apply same things everywhere. But yet, one of the concepts that I want to make sure is understood is that there's this concept that in order to achieve optimal pricing in healthcare, you have to have large numbers. And the reality is that's actually false. As we've evolved within our careers and what we've learned and how do you effectively procure healthcare goods and services, the one example that I'll use is, one of my partners is a clinical pharmacist who has actually built 2 prescription benefit management companies from the ground up, 2 PBMs. And we do a lot of work with health systems, any organization that's at risk for Medicaid, Medicare, commercial health insurance. We'll work with them on their PBM programs as well as self-insured plans. And what we've been able to validate is that you don't have to be in a consortium of 2 to 3 million members in order to achieve good pricing. We've actually observed in the market the antithesis of that a lot of times, depending upon who sponsors these consortiums, sometimes the money that's flowing between the PBMs and the sponsors of the consortiums, the pricing's just as bad as anything that we observe in the market. But what you do is if you can change the manner in which you procure healthcare goods and services and the way you contract at the local level, with local pharmacies, with local providers, with local hospital systems, and so on and so forth, it doesn't matter how big you are, the price is the price. It's the procurement process that's done in an open and transparent environment that allows you to basically understand that, having variable contract terms, when you eliminate those and you get to measurement of terms that are actually fixed and guaranteed, you can actually find that you get competitive pricing. So, one of the mantras that we use is that, our procurement process allows us to procure pricing for groups of 150 employees that is equal to or better than some of the pricing we see in these large consortiums that have 3 and 4 million members in them. So again, that's something that I think needs to be understood and needs to be a cornerstone of stepping out in the local markets and making sure that, you're basically achieving positive pricing, but that there's also equilibrium. Healthcare is expensive, and if you want a certain level of services delivered, there's a cost to that. But there also has to be a reality check to the need of having certain services provided at this level versus then being able to go to a regional level. And then in some cases, on some of the very high-end cancer cases and others, maybe you're in a regional or more of a national type of an environment. So here's a few major, areas that I think can have quick and significant impact on improving the cost of care. Is we've got to eliminate fee for service everywhere possible. That I think you'll find agreement across all segments of healthcare. Value-based primary care. I've talked about this, and you're probably sick of me saying it, but that is a huge component of moving forward. Transparent medical markets. Knowing the pricing and services prior to delivery. In my opinion, we as consumers have a right to know what services are going to be provided and at what cost prior to those services being provided. This concept that, we have something scheduled we go in, have services delivered, and we really don't know what our exposure is until 3 to 4 weeks later. I mean, that's just stupid. Shame on us as consumers for allowing that. So I think that that's something where there has to be huge amounts of education, but there also then has to be transparency of pricing. Case rates pre-negotiated, paying providers cash at the point of service, and having it done within a methodology that captures the data for the global management of risk. I think those are the types of things that we are doing today and can be done in today's market. And then eliminating and reducing out-of-pocket exposure to consumers and patients. I spoke of that earlier. That is a huge cornerstone of what has to happen. People can't afford the premiums and contributions they're paying, let alone, $5,000 to $7,000 out of pocket each year because they may have a chronically ill individual within themselves or their family. High performance specialty providers. That's an area where, if you take the capitated primary care and you have high performance specialty providers that are ranked on quality on their outcome metrics and are also willing to accept cash at the point of sale. It's amazing, especially in the COVID-19 environment, that if you're willing to pay providers immediately at the moment that they provide a service, that they're willing to negotiate cash prices that are massively more competitive than what the contractual allowed of any provider network is in the country. That's proving itself over and over, and it's accelerating in the marketplace today. Centers of excellence for the complex high-end services. This is following the leads of the Walmarts, of the Federal Expresses, of some of those large organizations. They have all basically done the homework, and the ability for smaller entities to follow the lead of what those organizations have done, and sending their hearts here, sending their cancers there, having orthopedic case rates and surgical centers. Those types of opportunities are available, and you don't have to be a Walmart, you don't have to be a Federal Express, you don't have to be a UPS, you don't have to be the federal government to take advantage of centers of excellence. And then second opinions. That's something that I think through the pre-cert prior auth process that the health insurance industry has really failed on second opinions because of the fact that most of it's become more just of a rubber stamp. But we're beginning to see that secondary review and independent review of recommended procedures actually is beginning to evolve back, because it's being physician driven rather than institutionally driven. And we're beginning to see a lot of value in having consults with specialists that can really add value and perhaps try to use alternative methodologies and settings before you ultimately get to a more of an acute care environment. So this is a model, and again, these slides are available, but this is really what we're talking about is, having a dedicated TPA based or dedicated payer based model, but it's in support of this primary care model, which could be clinically integrated networks, could be direct primary care, on-site clinics, a combination of all of the above. Looking at high performance specialists for both non-surgical and surgical, and then cash-based pre-established case rates that are paid at the time of service. This is all happening today. This is all in place right now. And then, looking at broad-based networks, that could be, your broad-based access, so that people, if they, are not in their local communities when they need service, that they still have access to care regardless, into either proprietary networks that are, based from this provider group, or carrier-based, or you could look at types of reference-based pricing or direct contracting. These are all methodologies that can be basically created in a community-based health plan environment. But, the majority of the case management, though, is delegated back into this primary care segment. So, that gives you kind of a visualization, hopefully, of a lot of the concepts that we've talked about through this. You talk about plan design, primary care, high value network, zero copay. PPO network, if somebody leaks out and they decide that they don't want to stay in the primary care, at a minimum a $75 copay. But non-network, meaning that there's no contract in place, 50% no out-of-pocket limit, that follows the ACA plan design type thing. But the key is that within this environment, you can avoid, surprise billings, you can avoid out-of-pocket exposure for non-network providers. And that's really a key issue. But let consumers basically walk with their feet, because when you give them a zero copay, it doesn't cost them to encounter with their physician. That's pretty powerful. When you get into the specialty side, into a high value network, there could be something as low as a $50 copay. That's still there and could be expensive for some folks, but you're stepping it down away from these types of deductibles that typically apply, and these types of out of pocket that typically apply to the plan as a whole. For the facility, when you get into those high expense type environments, in a high value environment, a 2,500 out of pocket or a 7,500 in the PPO. The key is you don't want to have these balance bill issues become such an albatross to the consumer that they're not getting the care they need. And then, in all fairness to the physicians and to the health systems, you also don't want patients defaulting on these $7,500 out of pockets to a point where the uncollectible accounts receivable that these physicians and health systems are chasing in the marketplace has almost outpaced what the total cost of uncompensated care was prior to the Affordable Care Act. I mean, think about that. The amount of accounts receivable that is uncollectible has just exploded in the market. So how do you bring and eliminate that issue and bring the health systems and the consumers closer together? Because if you can eliminate out of pocket and eliminate accounts receivable, then everybody wins. So I think this slide's probably the most important of all of them. If you're a Far Side fan, you've probably seen this, but I think this gets to the basic point that, there's a lot of choices. I present one opinion, everybody else has others, but I think the combination of a lot of these types of thought processes really will get us to the answers that we absolutely need to be thinking about.